Hi, this is an optics mock oral review. I've tried to categorize things in different sections. This is section one. The best approach, I think, would be to look at each question, pause the video, and try to answer it yourself, and then listen to the comments that I make. I'll certainly make some mistakes or some omissions, and please send me a comment through the system to let me know, and when we redo these, we can add your comments to it to make it more complete. So in this section, we're going to talk about traumatic aphakia, correction of astigmatism at cataract surgery, unilateral blurred vision, aberrations with refractive surgery, particularly LASIK, reduced near vision, fitting of toric soft contact lenses, and trouble with new glasses, which is always on the oral boards. So the first question is a 25-year-old with traumatic aphakia in the left eye. The right eye refraction is minus 5.00 plus 2.00, axis 90 degrees with visual acuity of 20/20. The left eye is plus 13.50 plus 4.00, axis 180 degrees with visual acuity of 20/50, improving to 20/20 with pinhole. And how will you treat this patient? Well, in the optics section, you should first look for spectacle solutions to problems. In this case, you have to worry about the anisometropia caused by the monocular aphakia. In this case, the spherical equivalent in the right eye is minus 5.00 plus half of the astigmatism, which in this case is plus 2. So spherical equivalent in the right eye would be minus 4. Spherical equivalent in the left eye would be plus 15.5. So the difference is 19.5 diopters, certainly way above the threshold of 2 or 3 diopters that most people can tolerate in the form of anisometropia. So spectacle correction wouldn't work. I think contact lenses are probably the next best approach in optic sections, and in this case you have two options. One would be if the patient wanted to just wear a contact lens in the left eye, and the second would be if they were willing to wear contact lenses in both eyes. First, focusing on the second option of wearing contacts in both eyes, the left eye probably would be best treated with a rigid gas permeable lens because they appear to have some irregular astigmatism. The way I know this is that the patient's aphakic, so all of their refractive astigmatism is caused by the cornea. They have 4 diopters of this, and their visual acuity only corrects to 20/50. But with pinhole it's 20/20, so that indicates that there is some irregular astigmatism. You could check this by doing standard keratometry and seeing the distortion on the Maugers, or better yet, do topography to document this. In any case, a rigid gas permeable lens would correct both the regular and irregular astigmatism, and this would be very helpful in this patient. In the right eye, you would need to do keratometry to determine whether the astigmatism in that eye was corneal or lenticular. If it's corneal, then that eye could be treated with a rigid gas permeable lens, just like the left eye, which would make care of the lenses very simple for the patient. If it was a lenticular astigmatism, then the patient would probably be best served with a toric soft contact lens to correct that astigmatism. The other issue in this case would be how to correct the near vision in the eye. Of course, the right eye probably accommodates normally, and many patients with unilateral aphakia when they're young can read quite well with just their one eye and not need special reading correction for the aphakic eye. Some patients require reading prescription for the aphakic eye, and some people require reading correction for both eyes. And this would be something you could determine in a trial frame after they get fit with their contact lenses for distance. The left eye could also be corrected for near in a monovision type approach, particularly if the patient is slightly older. that might be useful for the patient. If the patient just wanted to wear a contact lens in the left eye and wear spectacles over top of that, then the issue of the anisometropia then raises its head. If you correct the left eye for emetropia, then there will be 4 diopters of anisometropia, which they probably wouldn't tolerate. So you target over-refraction in the left eye with a contact lens fit. If you're not going to use a contact in the right eye, would be about -2 or -3, so that the amount of anisometropia would be reasonable for the patient to wear glasses over top of that. Now, if the patient is contact lens intolerant and you need to surgically correct the patient, you would need to, of course, look at the anatomy of the eye and see if there's intact posterior capsule to place a sulcus-based posterior chamber implant, or if the patient's going to have a sutured posterior chamber implant or even an anterior chamber implant. The target refraction in this case is really critical. Again, you don't really want to have a large amount of residual anisometropia that the patient would have to deal with their whole life. So you have to keep in mind that the right eye has a spherical equivalent of -4. So you would like to have less than 2 or 3 diopters of anisometropia. With the target, especially a sutured implant, can have some variation, and you need to take this into account. So you might assume that you could have 1 or 2 diopters of variation from your target refraction. So if you targeted for -2 over refraction, which would give you 2 diopters of anisometropia, and you were off by 2 diopters, you could then be -4 diopters spherical equivalent in the left eye with the implant, or you could be emetropic, and so emetropia in the left eye would probably leave the patient with a little too much anisometropia to tolerate. So I would probably target the refraction slightly closer to the -4 spherical equivalent that the right eye had, so that if it was off one way or the other, it wouldn't be too far off for the patient to be able to function. So I might target for a -3 in the left eye, and then if you're off a diopter either way, you'd still be within the range that the patient could tolerate. So I think this is really critical. The final point here is the correction of the astigmatism in the left eye with cataract surgery, or with a lens implant placement. I mean, the toric lens implants are not well suited right now for a situation like this. They're not really suitable for suturing in an eye at this point, and the irregular astigmatism, of course, couldn't be corrected for with a toric lens implant. So it would be better to use a spherical lens and correct the astigmatism with spectacles, or possibly with a contact lens if the patient was amenable to this. But correcting the astigmatism with a toric lens implant would probably not be wise or possible at this point. Next question is, a patient is referred for cataract surgery. The refraction is as such: the right eye plus 2.00, plus 2.00, axis 125. In the left eye, plus 3.00, plus 2.25, axis 85. Visual acuity is 20/40 and 20/60 respectively. Patient wishes to be able to see at distance and near without the aid of glasses or contact lenses. So your question is, how would you counsel the patient about how to proceed with cataract surgery so they could achieve their goals and tolerate the outcome? Until recently, it was very difficult to achieve the patient's goals with binocular solution where both eyes could be used together for distance and near, because multifocal lenses weren't available with toric options. Now they are, and so this is certainly a reasonable choice, and we'll discuss that in a minute. First, you really need to decide whether this astigmatism is corneal or lenticular by doing keratometry. If the corneas are both spherical and the astigmatism is lenticular, then your job is much easier. You just plug in the values for your IOL calculations and use multifocal lenses after properly disclosing their pros and cons to the patient. And you don't really have to worry about the astigmatism because it will be gone when you take out their lens. Most of the time the astigmatism is going to be corneal, and you will have to deal with that. You can then discuss the various options. As I mentioned, the multifocal toric option is certainly viable at this point and a reasonable option. The second option would be a standard multifocal lens with relaxing incisions, and relaxing incisions are not as predictable as a toric outcome, so you need to discuss this with the patient. The third approach would be a monovision approach with bilateral toric lenses or relaxing incisions. And the consideration with monovision would be the patient's ability to tolerate that solution. If they've worn contact lenses in the past with monovision successfully, then you can rest assured that they should be able to tolerate this with lens implants. If they have not tried it in the past, it's very wise to do a trial of this prior to suggesting this as a possibility with their cataract surgery. In my experience, about 50% of patients cannot tolerate monovision, so it's a significant number, and you would not want to give someone monovision if they cannot tolerate it. An option of mini monovision would be possible, and most people can tolerate a small amount of anisotropia, say 1 diopter or less, without difficulty, but that would not achieve the patient's goals of uncorrected vision being tolerable for both distance and near. So again, this shows the keratometry measurement in this case if the patient has corneal astigmatism, and this would be the keratometry measurement possibly if the patient had lenticular astigmatism. And if this is the case, then the astigmatism correction issue in this case can be ignored, which makes things much easier. Next question is: a 70-year-old patient presents with complaint of blurred vision in the right eye increasing over the past 3 months. Uncorrected visual acuity is 20/70 in the right eye and 20/20 in the left eye. The refraction in the right eye 6 months ago is plus a quarter with visual acuity of 20/20 in each eye. Today the refraction is plus 2.00 plus 1.50, axis 90 degrees in the right eye with visual acuity of only 20/25. The left eye is unchanged. So the question really here is what would cause a hyperopic and astigmatic shift in an eye in a monocular situation. So it's always helpful in these situations to kind of work from the front backwards. So from the front of the eye and the cornea, the kind of things that can cause a hyperopic shift and astigmatism would be corneal scarring or distortion such as Salzmann's nodular corneal degeneration or a pterygium that was progressing could cause this sort of refractive change. Some kind of traumatic scar could do this. In the lens, the typical change that happens is myopic shift with nuclear sclerosis, not a hyperopic shift. However, you need to look for sectoral changes in the lens that could indicate something going on in the ciliary body, like a tumor that could be causing a sectoral cataract and also causing a shift in position of the lens that would cause a hyperopic and astigmatic change. So the patient should have gonioscopy and possibly ultrasound to look for such changes. In the back of the eye, anything that brings the retina closer to the cornea will cause a hyperopic shift, effectively reducing the axial length of the eye. So any kind of mass in the posterior pole, such as a melanoma or any other type of tumor, posterior scleritis can cause this sort of a change also. Any kind of retrobulbar mass can also cause a shift in the axial length of the eye, causing a hyperopic shift. So B-scan is helpful, or even a orbital CAT scan would be helpful. So these kind of hyperopic shifts in the eye can be a significant worrisome sign and should be worked up. And again, working from the front of the eye to the back of the eye. Spherical aberration with refractive surgery is important to know about, because more and more of these patients are needing cataract surgery, and you need to address this with the cataract surgery. Normal eyes have positive spherical aberrations usually. Myopic LASIK tends to induce positive corneal aberration, and the type of surface that it creates would be a flattening of the central cornea, and it's an oblate surface. If you have a patient who needs cataract surgery and they have had myopic LASIK, you can assume that they have increased positive spherical aberration, and using one of the negative spherical aberration correcting lens implants that are now available would be helpful in correcting this and giving the patient better vision. If, however, they have had hyperopic LASIK, the patient has reduced spherical aberration and probably even has negative spherical aberration and has an increased prolate surface to the cornea. In that case, it's important not to use a negative spherical aberration lens, and it would be better to use a lens that had no spherical aberration correction, or even a positive spherical aberration correction. So it's very important in someone who's had refractive surgery to know whether they've had a myopic or hyperopic treatment, so that you can properly place the implants that will correct their spherical aberration correctly. Of course, if they have decentered ablation zones, the patient will need to have this evaluated, because this will not be corrected for with any implant really, and may need contact lens correction. So you need to sort out whether their blurred vision is due to cataract or from a refractive surgery related issue. And another question, we'll talk about the actual selection of the lens implant power in someone who's had refractive surgery, which can be problematic. These were just done to document the shape changes that you should know: oblate, spherical, prolate. Myopic LASIK tends to induce increased corneal aberration and can be described as an oblate surface. And with a hyperopic LASIK, you want to use a spherical or no spherical aberration correction lens implant. All right, next question. 35-year-old male with complaint of progressively decreased near vision in both eyes over the last 3 months. Visual acuity without correction is 20/20 in both eyes. Near vision is J5 in the right eye and J3 in the left eye at 14 inches. It's very important for the near point card to document the distance at which it's held. The card should say what distance it should be held, so that the Snellen equivalents are correct for that card. If you're holding it at 7 inches, the Snellen equivalent that says 20/40 is actually only 20/80, and so you're going to exaggerate the patient's vision at near. So you'll want to start out working up this patient doing a manifest refraction. In this case, assume that the manifest refraction is plano, and then you'll need to address the near vision problem by measuring the accommodation. There are several ways to measure accommodation in patients. One would be to have them focus at distance vision with their manifest refraction in place, and add minus power until they are blurred at distance, and that amount of power would equal their ability to accommodate. It's not a very real life situation, so a better approach would be to use the rod and to place the in this picture you'll see the Prince rule with the near point card properly positioned. It's important to check each eye independently. You'll hold the near point card in until the patient can no longer read the 2040 line numbers, and then document the distance at which that happens. So in this example, the patient sees blurred vision at 50 centimeters, so their accommodative amplitude would be 2 diopters. If, on the other hand, they were able to correct the vision to 20 centimeters, they would have amplitude of accommodation of 5 diopters. So in this case, with the patient assuming having only 2 diopters of accommodation, you would think that they probably would be having near point problems, because you can use your rule of thumb that you allow patients to use about half of their amplitude of accommodation to comfortably read. So if they're trying to read at 40 centimeters, you need 2.5 diopters of accommodation to see at that point, and a total of 5 diopters of amplitude of accommodation to be able to comfortably see at near. So if the patient only has 2 diopters, according to this slide, then that would be a big problem. So the next step in the examination would be to perform a cycloplegic exam. Prior to doing that, you want to make sure the patient doesn't have any extraocular motility issues that could affect reading vision. So in order to do a proper cycloplegic exam, we would need to use cyclopentolate 1%. Tropicamide does have some cycloplegic properties, but is not effective for really sorting out these sorts of issues. And drugs like scopolamine or homatropine or even atropine have too long of a duration to use effectively for the examination. So use cyclopentolate 1%, let the drops work for an hour, and then recheck the refraction of the patient, which is of course a cycloplegic refraction. And lo and behold, this patient has a cycloplegic refraction of plus 3.00 in each eye. So effectively, they've been accommodating 3 diopters to see a distance all the time, and they have a real amplitude of accommodation of the 3 that they're using for distance, plus the 2 that they could manifest in your exam. So their full amplitude of accommodation is actually 5 diopters. And if you fully correct them for distance vision and bring them back in for a post-cycloplegic exam on another day, you would find that their amplitude of accommodation that you would measure is actually 5 diopters. And if you correct their hyperopia, then they would be able to read again. A finer point would be the correction of the hyperopia. Many times patients don't tolerate the full correction initially. One option would be just to give the patient the 3 diopter correction and tell them to wear it whenever they're comfortable. And at first they'll just wear it for reading, but after another year or so they might find that they need it more and more for distance vision and are wearing it more commonly. Children, you can usually give full correction more readily, and they'll tolerate that easier. The next question is regarding the fitting of a toric soft contact lens. Assume you want the axis of the cylindrical correction to be at 90 degrees. The lens rotates 10 degrees clockwise on the eye. What axis will you order for the astigmatism correction? So there's an acronym for this. LARS, left add, right subtract. And this involves looking at the mark on the bottom of the toric self-contact lens. And if the lens is rotating clockwise, then the mark will then rotate to the left. So if you ordered a lens with a axis at 90 degrees and you put it on the eye where the lens was rotating clockwise 10 degrees, the lens would be effectively at an 80-degree margin. So if you wanted it to really be at 90, then you would order 90 plus 10 degrees or 100 degrees. If it moves to the right, as in this example that you're seeing, the lens that's at 90 degrees would actually be at 100 degrees. So if you wanted it to actually be at 90 degrees, you would order it at 90 minus 10 or 80 degrees. So it's really just looking at the movement of the contact lens trial on the eye and then making that particular adjustment. Next question. Patient has had the following glasses for several years. Right eye plus 2.00 plus 1.25, axis 180 degrees with a 2.5 diopter bifocal, and in the left eye plus 4.50 plus 1.00, axis 10 degrees, again with a 2.5 diopter add. You obtain the very same refraction, give it to the patient to get new glasses because their current frames are broken. Patient returns unable to wear their new glasses. How would you evaluate and treat this problem? So number one, you would need to make sure that the glasses were made according to your prescription. So you would need to describe how you would use the lensometer to measure the refraction in the distance correction and also in the reading correction, to document the optical center of the lens and make sure that correlated with the entrance pupil of the patient's eye. If the optical centers were off, that could cause induced prism, and that could cause some of the patient's problems. In addition, there's a litany of other problems that you need to look for to try to sort this out. One is to make sure that the base curves on the glasses are the same as what the base curves in the old glasses were. If you have a change in base curve in one lens and not the other, that can change the effective magnification of the lens and cause anisoconia symptoms. Anisoconia symptoms generally cause tilting of the world, and the patient can really have a lot of trouble walking and functioning with those kind of symptoms. Similarly, changes in lens thickness can cause magnification differences. With high corrections, usually higher than 5 diopters, vertex distance can have a major impact. The bifocal type can be a problem. In the past, hyperopic lenses, we would oftentimes use a round top bifocal instead of a flat top bifocal because that would give less image displacement into the bifocal. But in modern times, we generally use flat top bifocals for most situations because there's less image jump, and that's also very bothersome to patients. But if the patient had a round top bifocal in their old glasses, then it was switched to a flat top bifocal, or vice versa, that can cause problems. If the bifocal position is changed, that can similarly cause problems. If the bifocal was changed from a line bifocal to a progressive bifocal, that can cause changes. If the patient had a slab off prism in the bifocal of one of the lenses and you missed picking this up, that could of course cause problems. The patient has a significant amount of anisometropia between the glasses and will have some induced prism because of the difference in the near vision. They'll effectively have base up prismatic correction in the left eye when they're looking down through their lenses. Panoscopic tilt can cause induced astigmatic correction. And finally, lens material can have an impact because of differences in chromatic aberration. Some of the higher index lenses will cause significant chromatic aberration that can be bothersome to patients. Polycarbonate can also cause this problem. So here's a list of the issues that I would want you to check. Base curve, lens thickness and base curve can be checked with a Geneva lens clock. Lens thickness can be checked with a gauge. Vertex distance, optical center, induced prism, bifocal type, bifocal position, slab off, panoscopic tilt, lens material, and chromatic aberration. You would need to work with your optician to work all these things out so that you can effectively manage this patient's problems and not have any concerns. These can be very, very bothersome to patients. Hopefully you sort these things out before you give them the glasses so that they're happy campers. All right, that's this for this section. Thank you very much.